Good morning, everyone. My name is Dr. Rammohan Bhat. I'm a nephrologist at Narayana Hrudayalaya, Bangalore. At the outset, I would like to thank the organizers of Avatar and Medtronic India for giving me this opportunity to talk in this August platform. My talk is on care of tunnel dialysis catheter. I would like to talk on these points. For time constraints, I'm just going to run through. Most importantly, I would like to stress the importance of why we should give importance or care of catheter. It is necessary to prevent immediate and long-term infections, which actually have impact on central vein stenosis, which is one of the key topics being discussed in this conference. Infections could be related to the initial procedure. Infections could be exit site infections, catheter-related bacteremias. All these infections can be avoided with appropriate care, and we don't necessarily need to resort to fancy things like catheter locks, antibiotic catheter locks, etc., to prevent infections. We have to preserve central veins. For that, preventing infections is important. Choosing the catheter site placement is important. For that, we are told by Kedoki as well that we should choose a right IJ as number one option, right EJV, external jugular vein, as a second option, and not the left IJV as a second option. Then go to the left side of the neck before going to femoral, and then last is subclavian, because that has got a very high chance of central vein stenosis. And we should limit the number of catheters and the duration of these catheters by moving on to fistula wherever possible. It is very important to plan the catheter placements. Our care of catheters should start even before the catheter goes in. Most of the times, patients have already got a temporary catheter before we can put a tunnel catheter. So planning the tunnel catheter insertion is very important. We should not be pulling out the temporary catheter and putting a tunnel catheter after 1 hour, 2 hours, 3 hours, 6 hours. We should remove the catheter at least a couple of days in advance, remove the dressing a day in advance, do the shaving and skin preparation 1 day in advance, and then also scan the neck to see the patency of the vein 1 day in advance, so that we can plan the catheter placement properly, which is very important to prevent infections and get long life of the catheter. As I said, if you want to prepare the skin just before the catheter placement, don't shave, use a clipper to trim the hair from the chest, and always have a checklist and do a pre-procedure ultrasound so that you can minimize complications, which could be injury to the lung or injury to the artery, and also infections. This is a checklist that we use. I will run through this because of paucity of time. This is ultrasound that we do 1 day in advance, not 2 minutes before the procedure. On the right-hand side, you've just got some snaps which shows static views of the IJV at the top and the carotid artery at the bottom. The vein is more than twice the size diameter of the artery, which is quite good. But you can see that there's a small sheath which is developing where the previous temporary catheter has gone in. And then there's a pedunculated mass here, that's the sheath with the clot inside, which is there attached to the top of the vein all the way down. So we are going from top to bottom. You can see that pedunculated mass there all along the anterior part of the IJV. And this pedunculated mass goes into the subclavian vein where the IJV joins into the subclavian vein. However, the patent lumen around this pedunculated mass is quite a bit. So this person, you can do the catheter in the procedure room, in a dedicated procedure room, without the help of a C-arm. However, on the left-hand side, I've got this video where you can see the vein, which is compressible, which is very important sign to say that the vein is not completely occluded. We are going from top to the bottom of the neck. You can see the pedunculated mass coming somewhere there now. There you go. And the vein is as big as the artery, which is not very good. It's a very small caliber, and most of it is occluded with that pedunculated mass. So not much of space is left. And this pedunculated mass, this thrombus, extends all the way into the bottom of the vein and into the subclavian vein where the IJV joins into the subclavian. So that is not a good sign as well. So this patient, you should not be doing without, you can see this mass here extending into the subclavian vein. So this patient, you should not be doing the procedure without C-arm guidance and without a micropuncture set. So always do the procedure in a dedicated procedure room or operation theater, strict aseptic precautions, ultrasound guidance, and most importantly, use chlorhexidine. Multiple studies have shown that chlorhexidine 2% reduces the risk of catheter infections by more than 50% as compared to pyridine iodine. So always use chlorhexidine. And after the procedure, do not use Dynaplast. Use Tegaderm as much as possible. Use Dynaplast only if there is excessive bleeding. In patients who have got high risk of bleeding, like those who are still on antiplatelet, their platelet count is low or the venous pressure is high, you put a purse string suture at the exit site and remove this suture after 48 hours. That will reduce the risk of catheter bleeding post procedure. We usually remove the sutures holding the catheter after 4 weeks, because we see if we remove it at 2 weeks, the catheter migration rates are much higher. Dressing, various types of dressings are available. This one, which is the one that is most commonly used, the Dynaplast, is going to harm the skin, increases the risk of exit site infections. You cannot see the exit site. Here you can see the exit site very nicely. You can see the markings of the previous Dynaplast there, which has caused a lot of skin excoriation. So this is going to be much safer to the skin and reduces the risk of catheter exit site infections. And this one has got chlorhexidine impregnated pad in the middle. That is supposed to be the best, although studies have not shown any advantage over these clear transparent dressings. If you're using clear transparent dressing, this is how your pack should look like. It is very important that we take adequate precaution to reduce infection by cleaning the surface first. Don't do a bedside, exit site dressing change. You always get the patient to a dedicated area, clean the surface, get all the things opened up on the surface. Use a chlorhexidine 2% to clean the catheter and the exit site. Hand hygiene is very important. Using sterile gloves, very important. And you can see the person who's handling the catheter is using a gauze soaked in chlorhexidine without touching it, and then use a transparent dressing like this. I'll run through this. So whenever we connect and disconnect, first thing we do before we connect the patient to dialysis is exit site care. And as I mentioned in the previous slide, we changed the exit site dressing once in 7 days if the patient is use a chlorhexidine impregnated dressing, or once every other dialysis, not every dialysis, once in 4 days if the patient is using a clear Tegaderm or IV 3000. Always handle the catheter with gauze, which is soaked in chlorhexidine. Don't touch the catheter directly. You can see the person is cleaning the catheter thoroughly for 1 minute with chlorhexidine solution impregnated gauze. After cleaning the catheter, they are removing the cap. After removing the cap, the hub is cleaned for 1 more minute before connecting to the lines. After connecting to the lines, you can see that they're covering it with a gauze, a dry gauze. This is not impregnated in chlorhexidine. This is just a dry gauze. We've got a detailed video from Narayana, which you can access on YouTube as well, which is about 5 minutes and is very useful for dialysis technicians and doctors. So the role of various people, stakeholders who are involved in catheter care is very important. It's not the prerogative of the dialysis staff alone. However, dialysis staff take the majority of responsibility. They need to give attention to detail, what signs of infection, educate the patient about patient care, persuade the patient to get the better access like a fistula as soon as possible, and keep the patient informed of any problems. Patients should always wear a mask during the whole time they are on dialysis, not eat during dialysis, which is going to increase the risk of infection, and then get a AV fistula as soon as possible. If at all they wet their exit site or the catheter during bathing, they should come to the dialysis unit immediately, not after 24 hours or 48 hours. Doctors should avoid putting catheters, so get a fistula when patients are heading towards ESRD. Even if the patient requests catheter, try to avoid temporary and start with tunnel catheter. Even if the patient starts with a temporary catheter, try to move on to a tunnel catheter as a bridge between the patient presenting crash landing and getting a AV fistula. Coming to antibiotic logs, what Kedoki says is a low dose citrate is probably the best in terms of both anticoagulant and preventing infection, because it's an antiseptic as well. Beyond that, it says there is no real advantage of using antibiotic locks in preventing infections. Any unit should be having less than 1.5 catheter infections per 1,000 catheter days. Anything more than that is not acceptable according to KDOKI. If you do the things that I've already talked about, you can prevent catheter infections and get your infection rate below 1.5 per 1,000 catheter days. By just not doing those things, aseptic techniques, and just moving on to catheter locks, you cannot reduce your infection rates, and you're only going to create more microbiological resistance. KDOKI recommends that in those patients where they cannot have a fistula and they need to have catheter for long term, you could consider using antibiotic locks, especially if their infection rate is perceived to be high and your catheter infection rate in your unit is more than 3.5 per 1,000 days. With regards to anticoagulation, antiplatelets, KDOKI recommends that we should not be using warfarin prophylactically for all patients with catheter to increase the catheter patency, because it's not going to help. Low-dose aspirin may have a role, and most of our patients are on it anyways. Some troubleshooting tips: broken catheters, damaged catheters, we can always cut the catheter, and then we can always use a sterile hub that we always store. So in our unit, we have around 20 such sterile hubs that we have recycled and kept. So if there's a catheter damage, we just cut the catheter and reuse the catheter, get a bit more life from the catheter. However, during those procedures, we always cover them with antibiotics. Migrated catheter should not be kept for long, but if you want, you can keep it for 1 or 2 dialysis sessions, but then you might not get good flows and the risk of infection is high, so cover them with antibiotics in that period of time. For dysfunction, if there's a thrombosed catheter, you could use alteplase or urokinase. 2 mg alteplase is probably better, and just a push or a dwell is sufficient as per KDOKI. Thank you very much.